All right, so as promised, this course is really led up to the kind of the grand finale, the grand poobah, if you will, of what psychology is really about, and that's observing people, figuring out where there are abnormalities and dysfunction and distress, and then being able to treat that individual or groups of individuals to return them back to a normal level of functioning. And that's really what we're looking at here with if any of you are going into counseling or becoming a therapist or nurse or educator or whatever it is, this is really what you're going to be doing. You're going to be troubleshooters and then diagnosticians, and then being part of a team to help that person or that kiddo thrive in their environment. Okay, and it's tough to do. It's tough to do because, again, this is not a hard science. We can't say 1 + 1 = 2 every time. Sometimes 1 + 1 = 3, or not even, it could be 3.5 or something like that. So psychology is just very, very difficult to pin down one specific diagnosis that covers every set of or cluster of disorders. Okay, so looking at the individual can be sometimes tough because we've talked about this in the past. We got to take into account their genetics, right? What are they genetically predisposed to? Like, for example, if they have if there's some kind of genetic disorder or genetic dominant gene that affects their brain development, that might be a problem. They might have limited capacity in terms of coming up with strategies to overcome their daily challenges. Okay, so genetics are a part of that. Culture is a part of that. So depending on what culture they're from, that might dictate what kind of behaviors they're presenting, right? What are their family values? What have they seen? What are their personal experiences, right? All these things could come into play as to how we present ourselves to the outside worlds, either emotionally, thoughts, or behaviors. So psychology, I'm going to say psychopathology, I'm kind of getting ahead of myself, really looks into what do these clusters of symptoms and features tell us about that person. Are they functioning? Are they in distress? Or are they deviant from normal society in which they live, right? I'll give you an example for this. If you encountered a woman, say maybe you go to a church and you encounter a woman kneeling down at a pew, talking to what is seemingly her aunt who had passed away. Is that abnormal? What do you think? Is it abnormal to see a woman kneeling in a church talking to an aunt that passed away?
No.
No.
No. Why not? Because of why? Because of the context that we're in. That's kind of acceptable to do in church, is talk to icons or talk to deities or even people that have passed, right? Now, if you see an individual on a bus talking to their dead aunt, is that probably abnormal? Probably, right?
Yeah.
That's going to scare some people away because that's not a normal thing to do in that context. So when we talk about abnormal, it's very subjective, and we really have to look at their environment and where it's coming from. Okay, so I'm going to share my screen with you here just so I can kind of guide you along. Now, I know that we're kind of bunching a lot of like 2 chapters into one here. I'm not going to go too much into therapy today or treatment today, but I am going to talk about it a little bit as we go along with some of these disorders. Okay, so bear with me as I share my screen. All right, so you're going to hear this word a lot. It's called psychopathology. Now, psychopathology is, put simply, it's the definition for it anyway, is just the study of oh, is my screen not showing? What's happening here? Are you seeing my screen?
No, it's black.
Okay, what's happening? Oh, there we go. Okay. Oh, sorry about that. Let me go back. So psychopathology is sorry about that. It's the study of abnormal thoughts, feelings, and behaviors. Okay, so
We're still not getting it, or at least like I'm not getting it on my end.
okay, I'm sorry.
Yeah, I'm not getting.
How about now? Do you see it?
That's good.
Yeah.
Study of abnormal thoughts. Now, these are very important. Thoughts, feelings, or emotions, or behaviors. Okay. Now, what I want to pay your attention to is abnormal. Okay. Abnormal is a very subjective term, and it could mean something very different depending on where you go in the world or what culture you're immersed with, right? So, what might be weird in, like, the woman praying to her dead aunt might be normal in a church environment. It may cause a lot of people worry on a public transit system, for example. So we want to look at abnormal in the context of their environment. Thoughts, feelings, and behaviors, okay? Very important to pay attention to those, because just because somebody is not overtly behaving a certain way doesn't necessarily that they don't have thoughts or feelings that might not be normal. And we're going to talk more about that when we discuss things like depression and anxiety. Some people are very good at hiding depression, depressed thoughts, or even suicidal thoughts without overtly showing behaviors, but it's still considered abnormal because we're not designed to think that way. Okay, that could affect other areas of our life and quality of life. So psychopathology, by the way, is kind of, it's not a new term. It's kind of a more of a term that we use. It's readily available. You're going to hear the term abnormal psychology probably in your studies, especially if you're in psychology. So abnormal psychology, I don't like the term, and I think a lot of universities and institutes are changing that, because what it's doing is it's looking at these diagnostic criterias and these psychological disorders, and it's calling them abnormal. And abnormal isn't a very nice name. It's like saying somebody is strange or somebody is abnormal. That's a label that we're giving to somebody, and a lot of times it's unfair. And we already deal with a lot of stigmatization with psychology and mental health disorders that we don't need to call somebody abnormal or the condition abnormal. So we use the term psychopathology just because it's exactly that. It's just studying abnormal or deviant thoughts, feelings, and behaviors. Okay. So before we go into diagnostic criteria, it's important to understand how and why we need to look at somebody's conditions or clusters of symptoms before looking to make a diagnosis, right? And the reason I'm saying this is many of you probably can relate to it. How many of you have caught yourself saying, I have OCD, right? Or I have depression, or I have panic disorder over something, right? What you're doing is you're really generalizing a feature that you might have or you've observed in yourself or others, and you're taking that and putting a big label over it, like OCD, for example. That's a very common one. Somebody might have quote unquote OCD about something, right? OCD is a very specific condition which involves invasive thoughts to where the person can't function unless they act in a compulsive way to reduce that anxiety. And it's very well pronounced. So it's not as similar as somebody saying they're OCD because they're putting a fork in a spoon slot in their drawer. Okay, that's not OCD. That's being particular, and that's being specific and being organized. But calling it OCD would just be like really generalizing that specific situation. So in order to look at a diagnosis, now this is not diagnosing, this is looking at diagnostic criteria. We look primarily in three big areas, and I call these the 3Ds of psychology. Okay, we look at deviancy, we look at distress, and we look at dysfunction. Oops, got too carried away with my letters. No dysfunction. Okay, So if we can answer all three of these questions, is it deviant, is it distressful, and is it dysfunctional, then we can start considering looking at their symptoms, their symptomology, and matching it to the DSM, which is kind of our Bible for psychology. So deviancy, and again, this pertains to I'm going to change my color here, to thoughts, feelings, and behaviors. Okay, so if any of these fall into these three categories, or all three categories, we can look at diagnostic criteria. So deviancy, is it weird? Is it different from what the normal population of that person is doing in their culture or in their small, in their environment? Okay, so is it different? Is it abnormal? Okay, that's what we're looking at with deviancy. So if we can say, for example, the old woman talking to her dead aunt on the bus, okay, that we can say yes, check. That's not normal given her context. Okay, is it distressful? That's a tough one. How can we say that somebody's under distress? We can kind of observe that, right? We can see if somebody's uneasy with something, if maybe she's starting to shout at at her dead aunt. Okay, that would be distressing. Not only is it distressing for that individual, it might also be distressing for those around her. So we can really answer yes if it is distressful for that old woman or the people around her. That's a distressing thing, right? Dysfunction. Now, this is an important one, folks, because dysfunction is really overlooked. We can have something that may be abnormal and a little weird and different than what other people do, and it may cause us distress or other people distress, but it's totally within the guidelines of them functioning in society. They're able to wake up on time and go to their jobs. They're able to take care of themselves. They're able to have meaningful relationships, either with parents or spouses or significant others or partners. So dysfunction has to be really evaluated. Now, dysfunction is, are they not meeting their quality of life standards? Okay, so if you want to just put Q of L, is Q of L being threatened? Quality of life. So if we're looking at their livelihood, for example, this woman on the bus, maybe she had some kind of nervous breakdown, right? Some psychological episode that occurred in her life that she just started talking to herself. This is going to affect her job likely. If she's sitting in her cubicle talking to her dead aunt, what do you think is going to happen to her job? Probably be taken away, right? So her quality of life is going to be threatened at that. And that's what we want to avoid with psychopathology. Now, in many situations, for those of you that are going to be going out and working in the field of psychology, mental health, or social work or whatever, you're going to see people, for example, they're going to come to you and say, lately, I have not been sleeping. Okay. That's not normal. We should be getting at least anywhere from 5 to 7 to 8 hours sleep a night. And if somebody comes to me and says, I can't get to sleep for the past month, I haven't been able to get to sleep until I lay down at 10 o'clock at night and I can't fall asleep until 3, and I got to get up at 5 o'clock to start driving my truck into New York City. Okay. That's a big problem because that's not normal. It's distressful for that person because they're probably agitated, irritated, lethargic, all these bad things. So that's distressing for that person. And that might be threatening their quality of life very soon. May not be yet. They're getting up and they're doing it, and maybe for the past 3-4 weeks that things happen and that's acceptable. But now what's going to happen as we go into 6, 8 weeks, 2 months, 3 months, 4 months into these conditions still persisting? Now we're going to see a threat to their quality of life. They're not going to be able to function very long. So we in the profession want to prevent dysfunction. We want them to thrive. So anyway, that meets that when we meet these three, we start looking at, well, maybe we should look at their symptoms and figure out what that is. Okay. So and I think I said this earlier, our Bible for mental health disorders is called the DSM. And I'll spell this out for you. Diagnostic Statistical manual for mental health. I'm just going to do mental health disorders. And oh, I don't have it with me. Apologize. Give me a second. I thought I had it right on the code. Oh, there it is. Okay, sorry. Should have had this prepared for me. So this is what it looks like. The Diagnostic and Statistical Manual for Mental Health Disorders. We are currently on the 5th edition. This came out just a little bit ago, a couple years ago. And what it really does is it gives us, it breaks it down, and you can see I have nice little tabs here. So I can, I had to put these in myself. It took a while, but it helps me to determine like where something is right away. So I don't have to go through the, find the, table of contents, figure out what page I have to go through, and then flip all the way through there. So for example, I know that like anxiety disorders are usually, I have those as color coded as red. So if I'm looking for separation anxiety, I've got this tab right here, and I can open up right to that. And it's given me everything I need to know about separation anxiety. So one of the great things about this book is it helps us to not only give us a list of things that we can check off and say whether or not a person exists with these disorders, but it also gives us a little bit of a background from these disorders. Like, where does it come from? Where was it first observed? And what populations are we normally going to see like separation anxiety? It's going to give us like almost a history of where it comes from and what it is, what else it could be. So maybe it's not only separation anxiety they're experiencing, maybe it might morph into or manifest into features of OCD later, or maybe even some kind of codependency, or even affect their personality and turn into a personality disorder. Okay. So anyway, a lot of really good information in there. And on top of it, not only does it tell you where it comes from, what it looks like, and what else it could be, it can give you prognosis. It can give you treatment recommendations, things that are going to be most efficacious for treating it. It gives you comorbidity. With this, maybe alcohol or substance abuse is comorbid with anxiety disorders. Okay, so it gives you those as well. So anyway, a lot of great information in the DSM-5, and that's what we use when we want to make an accurate diagnosis. Okay, so within the DSM-5, it breaks things off into different categories. Currently, within the DSM-5, we have 20 categories. With over 250 diagnosable disorders. That's a lot, okay? As you can imagine, that's a lot. And that's really challenging if somebody comes in with a cluster of symptoms sometimes. But some of those categories that you're going to hear are, and I'm going to try and cover, I'm not going to be able to get through 250 disorders in this class, but I'm going to kind of just give you a general overlook of what some of these look like. So things like depressive disorders, okay, anxiety disorders. These are all categories of what we can see. We're going to see schizophrenia in there, which is a really interesting one. We're actually now looking at schizophrenia. I'm going to hopefully get time to talk about that. But when we look at somebody that is afflicted with schizophrenia, we're actually looking at that more as a neurological disorder as opposed to a psychological disorder. Okay, psychological disorder, it is distressing, it's dysfunctional, and it is deviant. However, it's not anything that can necessarily be treated with just learning new skills. Okay, there's actually firing going on, overfiring of the dopamine neurotransmitters. Just serotonin levels are all out of whack. There's a lot of things going on neurologically that schizophrenia may not be avoided just through behavioral therapy alone. So we are looking at that as being a little bit different than your run-of-the-mill mood disorder or personality disorder, anything like that. So we can include like neurodevelopmental disorders, stuff like that. Okay, so just, I'm not going to list them all here, but you get the idea. Personality disorders would fall under this. And depending on the category, the category really makes a big difference, because if I'm treating somebody for an anxiety or mood disorder, that doesn't necessarily mean that I'm going to start looking at personality disorders to help them out with a treatment process. Okay, and the reason being is mood disorders are generally on the surface, right? Moods are how we broadcast our emotions and our thoughts to the rest of the world. So personality is a little bit different. We can all change our mood several times throughout the day. It usually happens that way, but our personality doesn't really ever change. Okay, sometimes it might morph into something else or change a little bit, but for the most part, if you remember our section on personality, it remains relatively stable and intact throughout our lives. Okay, unless something major happens. So that's where we turn to get our diagnosis. Okay, so how common are psychological disorders? A lot of studies say that they're much more prevalent than what we really are aware of. Okay, one of the sources, I think in your book, estimated about 26% of Americans over the age of 18 have a mental health disorder in any given year. So that's roughly 61 million people in the US. Now that's just diagnosed. Those are people that have recognized they need help, or somebody else recognized they need help, and they go in to get the help. If you can imagine, there are probably far more people out there that don't have a diagnosable disorder with them. And that could be for many reasons. What do you think is a reason that people would not go in to seek help?
They could be like scared to face the truth, or just like nervous to go, or embarrassed.
Okay, yeah, embarrassment is a really big part of that. Remember at the beginning of this class, I told you we as humans are two things. Does anybody remember what those two things are? Anybody? Should offer bonus points if anybody knew this. I don't know. I can do that, but anybody want to take a stab at it? We as humans are two things. Okay. We are lazy and we are proud. Okay. Now, lazy, I say in the most lovingly fashion, because we like routine. All right. We know that. We like to have things routine. We like to have things in a system that just makes sense. We're very organized with our minds and our thoughts and our behaviors. So that's what I mean by laziness. But we are very proud. It's hard for us to admit that something is wrong or that we are wrong, because the world exists in our confidence that we're comfortable in our surrounding. And when that doesn't happen, that challenges our own view of whether we're reliable in making good assessments for ourselves. So psychological disorders might be hard for somebody because they're proud. How about like typical males? What do you think? Females versus males, and I'm using gender kind of like old school gender roles. I know things have really changed a lot with this, but like let's kind of get in our time machine, go back in the 70s and 80s, and we're talking about males versus females. Who do you think really lacked reporting accurately psychological disorders, males or females?
Is it males?
What's that?
Is it males?
Males, right? Because the traditional role of the male was to what? Not cry, be tough, and beat up whatever it is that you you didn't like in your environment, right? So gender role expectations had a big part of that. I think we're seeing a lot more change with that. I can gladly say I'm seeing a lot more people coming in from all sorts of whatever gender they identify, or whatever gender role that they identify best with, coming into my practice, which means that we're starting to normalize psychological disorders. So that's one of really the biggest challenge is normalizing and letting people know that 26% is huge. 26%, that's a quarter of the population. That means out of this class, I can't see how many people are in this class, but say there's 20 people in this class, chances are that over 5 of us have a diagnosable psychological disorder. So that's a huge number. And probably even more than that, that aren't coming forward and saying anything because of maybe pride or embarrassment, or maybe they feel like they can handle it themselves. And maybe you're right. I'm not saying everybody has to go see a therapist, but if you think of it in terms of medical profession, if you have your knee starts bothering you, right? That's kind of normal. Many of us have probably experienced knee pain, but going back to what we know about diagnosing, right? Is it normal? Probably not. Is it distressful? Well, yeah, it hurts. Is it dysfunctional? Well, I can't go to work today because my knee hurts. Now we have a dysfunction. And what would you do if your knee hurts so bad that you couldn't go to work or go to school or jog or whatever? You're going to go to the doctor. And that's kind of what you want. I'm kind of bringing this back around full circle. If you are able to evaluate yourself and say, something's not right, maybe I should go talk to somebody, or maybe I should direct so-and-so to go talk to somebody, because usually they're out and about and they're socializing and they're having a good time with me. But for the last 2 weeks, they've just barricaded themselves in the room. I know social distancing, it makes it a little harder to do that. But certainly, if you're picking up on these signs, you can say, hey, maybe you should go talk to somebody, or you can talk to me, and we can kind of figure things out. Okay. With that, I also want to kind of bring up the idea of labels. Okay. We use labels. I mentioned that we have 250 diagnoses in the DSM-5. And what they do is they help us to medically, important word, medically treat an individual based on their cluster of symptomology. And that's great. It's great that we have evolved psychology so much that we can include the medical model to doing this, to diagnosing somebody and treating them. But with that comes labels. And that kind of goes back into this pride thing or embarrassment, right? Embarrassment. So 2 R's, I think. Is that right? I don't know. So that might be embarrassing for somebody to say, I have OCD, or I have schizophrenia, or I have bipolar disorder. I have, whatever it is. Some people may not like those labels, and that could be off-putting. The other way that labels are really difficult with psychology is some people seek them, right? Some people, like, we joke around about OCD. We say, oh, I have OCD about my utensils in my drawer. That's a problem, because that is not only stigmatizing, but now we're engaging in labeling somebody. So if, for example, and I'm going to use PTSD. I think PTSD is a very serious disorder, and it's probably one of the tougher ones that I have to deal with, because there are a lot of things going on. First of all, they isolate. They're embarrassed about talking about their problem, which is why they're re-traumatized by it. But yeah, PTSD is a very difficult thing to go with. Diagnosing somebody with PTSD, it's helpful because we can get them the treatment that they need. If we have to justify to their insurance company that they need to go to hospitalization or maybe even a detox, and they have a PTSD diagnosis, that's going to be helpful for them for billing. Okay, so that's important. Where I have seen labels backfire is where somebody just becomes hands off. They say, well, I have PTSD. I don't have to work towards anything because that's just what I have. It can be a showstopper for some people, not all. I'm not making a blanket statement here, but I have seen that happen. I recall in my practice a young woman many years ago who was afflicted with bipolar disorder. and she was married. And frequently, when she became manic, which I'll talk about on Friday, some of these disorders and how they look. When she became manic, she would go out and have an extramarital affair, multiple extramarital affairs. She would sleep around and her husband didn't know about it. And when she was confronted about it, her response was, I have bipolar disorder. It's okay. That's kind of how she was thinking. So it can be very limiting in the therapeutic process, but I just kind of wanted to bring that up. And again, I'm not saying anybody that has a label does that, but I do see that occur. So we want to be very careful as to what these labels are. And I have this conversation with my clients all the time. I explain to them, this is what I'm diagnosing. This is what this means. I hope that this label, this isn't anything that you internalize and that you're going to stop the process of getting better. And most people really, really do work towards fixing themselves, but it does happen from time to time. So any of you that are going in the field, just kind of keep that in mind with labels. Okay. So that brings me really to, I do want to talk about some psychological disorders, some specific ones like anxiety, a little bit about PTSD and how stress affects that, and phobias, and delve into what personality disorders look like. However, we're running up on time today, so I'm going to stop here and we'll pick up where I left off on Friday. Are there any questions? Where is my...
I just have a question regarding my grade, but
Okay, if you want to hold tight just a second here, I will talk to you offline.
okay.
All right, are there any other questions? Does anybody have anything to add? Does it kind of make sense as to how we look at diagnosing individuals using the DSM?